Okay, good morning, everyone. Thanks for joining us for week 3 in this ECHO series. And there are some changes overall to the group that we'll discuss in a moment. So some our usual reminders about any assistance, please contact Rick for any technical issues. You can contact Claire or you can contact me directly anytime with any other sorts of questions. Our didactic presentation this morning will be by Kathleen. She's going to talk about new and emerging treatments, and Kathleen and Danette are going to discuss our 2 cases, and Amber will be presenting as well. These are our disclosure statements. You can read these as at your leisure. Person-centered language recommendations, again, takes practice and multiple reminders. Please keep these in mind as we go through the series. And off to you, Kathleen. Take it away.
So I'll move on to the next slide. We're going to be talking about type 2 diabetes and pharmacotherapies. So our first objective is to describe the GLP-1s and SGLT2 inhibitors currently available. Our second objective is touch a little bit on the future landscape of diabetes pharmacotherapies. And thirdly, I will update everyone on the Medicaid coverage. Okay, so the American Diabetes Association standards of care are constantly being updated. And in the past year, in fact, a couple of notable changes have occurred. So I wanted to go through this algorithm. This is actually a simplified version of what you will see in their formal published guidelines. So it used to be that metformin was the standard baseline kind of therapy, but they've really gone away from that as being the standard go-to, but really trying to emphasize that you consider other patient-centered factors, compelling indications for if it's really the best choice or not. So in particular, this was in the previous guidelines, but maybe not quite as explicit. If someone has atherosclerotic cardiovascular disease, heart failure, or kidney disease, and they don't need metformin for glucose control, then you should consider one of the other therapies. So it branches off to that group of boxes on the left there. And so this should be regardless of A1C, glucose target, or metformin. You should consider one of these therapies based on the different categories here. So if it's atherosclerotic cardiovascular disease, you can use a GLP-1 or SGLT2 inhibitor with the caveat that it should be an agent that has shown proven cardiovascular benefit. And if the A1C is still above target, then you could add the other agent, or even actually think about a low-dose thiazolidinedione, because those have shown some cardiovascular benefit. And the second, the blue box, if the patient has evidence of heart failure, and now we actually have some evidence that even heart failure with preserved EF, the SGLT2 inhibitors are preferred. Then the third category is chronic kidney disease with or without albuminuria. So if the patient has albuminuria, there's proven benefit of SGLT2 inhibitors. And if not, then you consider this patient to be a high cardiovascular risk patient, and therefore you can consider either a GLP-1 or an SGLT2 inhibitor. And then again, if A1C is still above target or there's a contraindication or intolerance, then go to the GLP-1 or SGLT2 alternating. And then you can think about additional agents based on the need for glucose control and other factors, and if patients do not have these underlying conditions. And this will include, go ahead and advance, hypoglycemia, weight gain, and cost as potential factors previously mentioned in the guidelines, but I will also show you here as well. So for hypoglycemia, we have the 4 classes of agents, the SGLT2s and GLP-1s, as well as DPP-4 inhibitors, which should not be used in addition to the GLP-1s and thiazolidinediones. If you need to use a sulfonylurea, use a later generation sulfonylurea. And of the insulins, Degludec and glargine U300, otherwise known as Tresiba and Toujeo respectively, tend to have less hypoglycemia than other basal insulins. If weight gain is the primary concern, which I would say 90% of the time, it is one of the biggest concerns, the SGLT2s and GLP-1s are the most effective in terms of promoting weight loss. And then using those in combination as needed, and you would minimize sulfonylureas, insulins, and thiazolidinediones. Finally, cost is the other factor. Of course, metformin, sulfonylureas, or thiazolidinediones are the cheapest agents. Some of your human insulins like NPH and regular insulins tend to be the cheapest if that is necessary. And then you kind of just repeat the cycle. And keep in mind here in this right upper hand box that this is all on a background of lifestyle interventions, diabetes self-management education, weight loss, if appropriate. Next slide. So just a bit more on the GLP-1 receptor agonists. Next, we can divide these between the short-acting GLP-1s, which we really aren't using that much anymore because they're not as effective in terms of A1C reductions, but they can be used. For example, lixisenatide in combination with glargine in a single dose injection once daily offers a more simple option. And then the longer acting next. So all of these, even though they are not all given once weekly, liraglutide, for example, once daily is considered a long-acting GLP-1, and it's because they cause continuous activation of the GLP-1 receptor, and that results in better A1C reductions, better fasting glucose reductions, and ultimately tend to, not always, but tend to cause to have better tolerability. And these agents also, because they have continuous activation of the GLP-1 receptor, then the effect on gastric emptying tends to exhibit some tachyphylaxis. And so you really don't see much prolongation of gastric emptying once the patients are at steady state. And so that enhances better tolerability. Now, a few cautions to think about. CCL tumors and medullary thyroid cancer are actually haven't been established in humans, but they've been identified in rodent studies. Rodents have very different C cells, and humans have almost no GLP-1 receptors. So it's still more of a theoretical risk, but still a black box warning. Be very careful with their use with chronic kidney disease, particularly if you're going to start an agent and the patient becomes nauseated. Acute kidney injury has been reported. I would still, even with the effects on gastric emptying being only temporary for some of these agents, I would not use them in patients with gastroparesis. And then acute pancreatitis is another contraindication or caution, although it's not really been identified in any of the randomized controlled trials. It's something that the FDA is still monitoring. So the SGLT2 inhibitors are shown here. There are 4 of them, and they're starting in maximum doses. They work by blocking renal glucose reabsorption. And of note, in patients who have an eGFR of less than 45, you aren't going to see much glucose lowering. So if you're going to use them, it would be for the purpose of cardiorenal benefit and not for glucose control once that GFR drops. And the major they have similar reductions in weight compared to GLP-1s, at least the head-to-head studies that have been done, not the newer agents and doses. But in general, tend to have a little bit less A1C reductions. And you can see a small rise in creatinine, just as you would see with the ACE inhibitors or ARBs. And that should not be a reason to stop this class of medications, because ultimately, they will catch up and have benefit long term. Now, the cautions include urogenital infections, incredibly common. There is some very limited evidence that if you use if you provide genital hygiene advice, that it's supposed to reduce that risk. I'm not real convinced that that's effective, but it's there. It can cause some fluid and electrolyte issues, and I've had patients stop these medications just because of overwhelming polyuria. And so I personally, with very little evidence, tend to try to get the A1C levels down to maybe under 9% or so before starting it, especially if they have a lot of polyuria at baseline. They also can cause euglycemic DKA. Then the other, and this is primarily in patients who've had diabetes for a long time. So think about that in those patients who are on multiple injections of insulin per day. And then canagliflozin in its cardiac outcomes trial showed some increase in risk of amputations. It was not shown in any of the other cardiovascular outcomes trials. So it's unclear really if this was just a chance finding or an actual issue. I would say if someone has an unstable ulcer or bad, osteomyelitis or really bad lower extremity disease, then you might kind of think twice, or at least kind of weigh your pros and cons. And then the new kid on the block is tirzepatide. So this was just approved by the FDA in early 2022, and it is the first GLP-1 GIP analog. And this is the head-to-head study with semaglutide. And unfortunately, at the time of this study was designed, only the 1 milligram semaglutide dose was available. So we don't really know how it would perform head-to-head with the 2 milligram dose. But nevertheless, there was a superior A1C reduction and weight loss. So here you can see the A1C reductions with the highest dose of tirzepatide, which is 15 milligrams versus 1 milligram. And there is about a 0.45% difference in A1C. And they had similar tolerability, and the weight loss was also superior. So in this 40-week study, there was an additional 5.5 kilograms of weight loss compared to semaglutide. So that is definitely noteworthy on both accounts. We don't have the cardiovascular outcomes data yet, so that is another caveat to consider. But this is a very promising new approach to therapy. So in the end, we're left with a lot of reasons to use the newer drugs if you can. And just kind of summing up when you would use one versus another. So for the SGLT2 inhibitors, definitely if someone has heart failure, also potentially cardiovascular disease, in particular cardiac disease, and its renal benefit, keeping in mind the limitations for A1C. For GLP-1s, definitely used for cardiovascular disease, and also think about preferentially using these for stroke. So if you look at the individual endpoints in these trials, and there's some meta-analyses that support this, that there seems to be a little bit more favorability for GLP-1s versus SGLT2s. Possible renal benefit as well, although it's not as dramatic as with SGLT2 inhibitors, where you actually see reductions in doubling of creatinine, and better A1C reductions. Both of them cause somewhat, pretty good weight loss and no hypoglycemia. And this is one of the meta-analyses that I was referring to. So you can see here 3-point MACE reductions, and this is not including a couple of the newer cardiovascular outcomes trials. So there is one that's published more recently that's kind of similar results. In terms of non-fatal stroke, you can see there's a little bit more benefit with GLP-1, that's in panel C. And hospitalization for heart failure, there's even a tiny bit of benefit possibly, and this isn't real clear, but with GLP-1s, but definitely favors SGLT2 inhibitors. And then you look at the renal outcomes, similar situation there as with heart failure. All right, so Let me just give you a little bit of a flavor on the future therapies, because you could do an entire talk on this, and sometimes this is a subject of whole lectures. But some of the things that we are likely to see on the horizon include a once weekly basal insulin. Sounds kind of scary, but in the clinical trials, it was actually non-inferior in terms of hypoglycemia. And so this, one might imagine that you might even be able to mix the once weekly basal with a once weekly GLP-1 and actually really simplify regimens. I think this would require some education on the part of patients, and certainly for hypoglycemia avoidance, but in the clinical trials seemed to be favorable. There's also, so those are in phase 3 clinical trials, and those are actually, we could see the light of day in the next couple of years. The next one that's a little bit farther out is glucose responsive insulin. So I don't think this has made it to phase 3 studies yet, but there are insulins, at least one under development, that is actually responsive to ambient glucose levels, and so presumably would result in much less in the way of hypoglycemia. And then this concept of combined peptides. The background surrounding this is that we see a lot of weight loss following bariatric surgery, and we think in part due to the disruption of the incretin axis and multiple hormones that are involved. And so actually some studies using multiple agents, kind of this triple cocktail, which I have here with the GLP-1, glucagon, and GIP, have really shown weight loss that is on par with what we would see with bariatric surgery. So this is going to be kind of the wave of the future. There are lots of agents under development, so I think we'll see more of them coming online. And then there are several others that I won't go into a lot of details because they're a little bit farther out, that can potentially provide some, additional options. And in particular, one that I'll call out is the PPARs. So that's what your pioglitazone the thiazolidine diones belong to. And the idea there is to have a safer insulin sensitizer that doesn't cause weight gain. And then some novel mechanisms of action, like the glimins, I don't know if I said that right, which can affect mitochondrial dysfunction. Because there are so many therapies out there, why do we need additional therapies? And what I think it may come to is this idea of precision medicine, which is rather well developed in the cancer world, but not so well developed in the diabetes therapeutic space. There are lots of publications in identifying adult onset diabetes phenotypes or subtypes. And those are really crude way of implementing precision medicine. And certainly the genetics and the pharmacogenetics or pharmacogenomics aren't quite there, but that would be another obvious, potential target for the future. So identifying these patient level markers to understand and predict the response to therapies and complications, and more importantly, also making sure that these are equitable. Then the other thing that I think we will see is really understanding how and when to best implement treatment for prevention of progression. So I had to turn my slides in before this study was published, but just, in the last week, the GRADE study was published, and that compared several different classes of therapies as as add-on to metformin therapies to identify what is the durability and also maybe even some other potential benefits. And what they found is that the GLP-1 that was used, which was liraglutide, had greater durability than a sulfonylurea. And I think that's probably not surprising based on some older data. The sulfonylureas don't last as long. And potentially insulin also. So going back to that, back and forth to insulin. So there are some data that early combination therapy in some patients will extend that time to treatment failure. And it's that time to treatment failure where patients become vulnerable. And then lots of technology advancements, connected devices for monitoring and treatment. Next slide. So now I want to just move on to the changes in the Ohio Medicaid and managed care plans. The formulary did change in the past, 6 months or so. And the major change is that step therapy was removed for a lot of medicines. In fact, the only one that I saw requiring step therapy now was Degludec. And so you can see, from that perspective, the Glargine U300 is still a very good choice and tends to cause less hypoglycemia than normal Glargine. So that could be a consideration for you, but you can use any of these GLP-1s and SGLT2 inhibitors and not have to worry about it bouncing back to you for prior authorizations or step therapies. The other news that just came out maybe a couple months ago is that Ohio Medicaid has now made continuous glucose monitors available without the need for a prior authorization, which is huge. And you can send them to the patient's local pharmacy. So that removes a lot of barriers that were there. And that's all I have.
Okay, thank you so much, Kathleen. Great presentation. I had one question before we move to the larger group, and that is, you mentioned something about GFR thresholds and prescribing SGLT2 inhibitors. Could you just repeat that?
Down to as low as eGFR of 25 okay. In many cases, and see renal benefit and or cardiac, heart failure benefit. But once that eGFR drops to maybe 45 or so, you really don't see much A1C reductions. It loses its glucose lowering efficacy. So you still may need them, but for different reason.
Okay, thank you. That's helpful. Any other questions for Kathleen before we move on to our cases?
Just briefly.
I had one question before we move to the larger group, and that is, you mentioned something about GFR thresholds and prescribing SGLT2 inhibitors. Could you just repeat that? I didn't quite catch the whole message.
Yes. So there, depending on the SGLT2 inhibitor, first of all, there are different dosing recommendations, but you can use these down to as low as eGFR of 25 in many cases, and see renal benefit and or cardiac, heart failure benefit. But once that eGFR drops to maybe 45 or so, you really don't see much A1C reductions. It loses its glucose lowering efficacy. So you still may need them, but for different reason.
Okay, thank you. That's helpful. Any other questions for Kathleen before we move on to our cases?
Just briefly, one, is inhaled insulin going to be a thing of the future or not? And then two, when you're looking at the GLP-1s, is there a dose that you really need to hit? I mean, a lot of patients seem like they can only tolerate the lower dosages to see those sort of are they class effects, or is there a dose dependency too?
There is definitely a dose dependency, and some of the GLP-1s are more tolerable just because they were, the way the dosing strategy worked out. But yeah, so the lowest tolerable dose, and because there is that adaptation of the GLP-1 receptors, I would say you could start off low and just leave them on the dose for a few months, and then maybe that you can slowly work your way up.
Kathleen, this is Debbie. I have a question particularly with regards to the GLP-1 tirzepatide and impaired fasting blood sugars. So I've had a couple patients, 3, that have showed up actually wanting the Mounjaro because of the lay literature out there with weight loss associated with it. Is there any data in at least pre-diabetes or the impaired fasting blood sugars with this? I guess the whole class we have for the GLP-1s, but the GLP with the GIP analog? Is there any data out there that you know of?
They have a separate clinical trial program for obesity, I believe, and we should be seeing that data. We definitely see that with the higher dose of semaglutide, and it definitely is very effective for preventing diabetes. So I expect this will be very similar, if not better.
Thank you, Debbie. Okay,
I
think we can go ahead.
I wanted to comment about Mounjaro. The pharmacist in our practice is getting people, can't be Medicare or Medicaid, but anybody with a commercial insurance is eligible to get a discount coupon for $25 a month for use of Mounjaro for obesity. And we're seeing really great results with it, like dramatic.
Yeah, so a number of companies, including Novo, have offered discount coupons for up to 6 months for Wegovy, for Saxenda when it was out a couple of years ago. There's a few challenges with that. I think one is supply. They've had some supply chain issues. I know Mounjaro is reasonably well available. And then what do you do once the 6 months are over with is another question. Of course, it's useful for kickstarting weight loss or diabetes control. What excites me is some of the first GLP-1s going off patent next year. And of course, once they go off patent, it still takes a couple of years because there's only going to be one generic manufacturer. But I estimate in the next 3 to 4 years, the price is going to come down quite a bit. We are out of time, so let me turn it back to Claire for a moment.
Yeah, so just real quick, Rick, go ahead and next slide. I'm sending the post-clinic survey to you right now, so it should be in your inbox within the next minute or so. If you have any questions, please reach out. I will say we have a couple empty spots for cases, so if anyone has an additional case they'd like to submit, please email me and let me know. Otherwise, we'll see everybody next week for Adam's talk on wearable devices.
Thanks, everyone. I know there's still a few questions and comments, so feel free to email Dr. Dungan or Dr. Healy anytime. Well, I shouldn't speak for them, but if you have any questions, I'm sure they'd be happy to answer them, and we'll see you next week. Take care. Bye-bye.